committee meeting. This is an open meeting, so we have a lot of participants online. It's the reason why I needed to come. You're saying this is not turned on? Is that what you're telling me? It's on? Okay. Thank you. This is an open session, and I want to first welcome our panel participants. Thank you so much for your willingness to be here, for the preparation that you did prior to today. We so appreciate the expertise that you're bringing to the table and our opportunity to dialogue with you about what you know and how it will inform our work. So special thanks to each of you. For those of you in the room and who are participating online, you might be interested to know that, as I mentioned, this is an open meeting. We have about 1,500 sites across the country that have RSVP'd in advance of this session to listen in on this session. And at a number of those sites, there would be more than just one individual. In some cases, of course, many individuals. So a lot of interest in the conversation that we're having this morning. This is the final open meeting of the Future of Nursing 2030 Committee. There will not be other meetings. All of the rest of that will be open. All of the rest of our work will be done in closed session to continue to push forward on the development of the report. For those of you who are participating online, I just want you to know that there's a handout with information that includes today's agenda and the information on the speakers. That should be available and appearing for you on the right side of your screen, as are any of the slides that are going to be used today. You should be able to see those. Those are available as well. Also, for the participants outside of this room, we will not be taking any external comments. There won't be an engagement between the panelists and public commenters today. But please do, based on what you're hearing, share your thoughts, observations, recommendations with us by email. And that email address you should send that information to is also listed and available in the handout, and you ought to be able to see that from wherever you're participating in today's meeting. So please know that from both the panelists that are participating and from all of you that are dialing in, this is still an information gathering session, and we welcome your input to provide it to us in the way that I just described. As a committee, we're still in the process of pulling together information. This is one part of that process of assembling materials. We're continuing to push forward on our gathering data, evidence, expert opinion, and so on, as we then begin to turn our attention toward drafting chapters of the report and ultimately the recommendations as well. As all of you know by now, the committee will take into consideration evidence. We'll be deliberating thoroughly, not just what we hear today, but what we've heard in site visits, et cetera, up to this point, and incorporating information into the draft report. And a reminder that once we've done all our work, the work of the report is not finished. The report draft itself must go through a very rigorous review process by experts who are not known to the committee. They are anonymous to us. And so as you're hearing the dialogue today, know that there's still a lot of the work of the committee that stands in front of us to be done. This is an information gathering session. So I wanted to share that much with you, and especially for those of you that are participating online. Our discussion this morning is a number of wonderful experts that have joined us, and it will be moderated by one of our wonderful committee members, Maureen Bisignano, who is a President Emerita and Senior Fellow at the Institute for Healthcare Improvement. And with that, Maureen, if it's all right, I'm going to turn it over to you. Thank you. And thanks again to the panelists.
Thank you, Mary, and it is such an honor to be moderating this panel. First, welcome to everybody who's online, and we'll have a vibrant discussion, I know, given the input that we're going to get from these amazing speakers. So this morning, we're going to have brief presentations and then a lot of conversation, I'm sure. Tricia McGinnis is Executive Vice President and Chief Program Officer for the Center for Healthcare Strategies. Angela Patterson, Chief Nurse Practitioner Officer for CVS Minute Clinic and Vice President for CVS Health, and on the board of the Rhode Island Nursing Middle College, which I had the great pleasure to visit last week and just filled with energy from that site visit. Elizabeth Mitchell, President and CEO for the Pacific Business Group on Health, is going to join us by Zoom. And then from the American Hospital Association, Prija Batista, Vice President for the Value Initiative for the American Hospital Association, and Robin Begley, American Hospital Association Senior Vice President and Chief Nursing Officer for the American Organization for Nurse Leadership. And then following our discussion, and we'll take a brief break and then hear from Laurie Melikar, Senior Director for Programs at Robert Wood Johnson Foundation. So, Tricia, let me invite you up, and I'm really excited to hear from you all.
And I forgot my clicker. Good morning, everybody. It's really nice to be here and to share some Medicaid perspectives that could be helpful to your work. My name is Tricia McGinnis, and I'm with the Center for Healthcare Strategies. I'm going to focus my comments on where and how Medicaid agencies are thinking about social determinants of health work, how they're leveraging some of their policy levers to try to advance that work, and highlight some implications of that for the future of nursing that hopefully will be helpful for future discussion. So with that, okay, yeah, I think that's working. For those of you who are not familiar with the Center for Healthcare Strategies, we are a nonprofit technical resource center. So we work primarily with Medicaid, state Medicaid agencies, Medicaid providers, and Medicaid health plans, really to help them advance innovative policies and programs that are intended to ultimately improve the health and well-being of Medicaid beneficiaries. We provide technical assistance, and then the work that we do with our stakeholders, we then disseminate more broadly in the hopes of really trying to help others learn and scale from the innovation that they're doing. We have three work streams that we really focus our work on. One is broad-based delivery system and payment reform. The second is work with patients with complex care needs and the specific programs and policies to support them. And then finally, supporting Medicaid leaders and growing their leadership capacity. And I will just say in the work that we've been doing around social determinants of health, this really has cut across all three of those buckets of work that we do. But like I said, I'm going to be focusing my comments really on kind of the Medicaid agency and Medicaid director perspective and how they're thinking about social determinants of health work and, again, implications for nursing. So with that, just to tee up the conversation, so Medicaid directors have always known that social determinants have been a huge factor in their enrollees' lives. That has not been in dispute. I think it has not been, though, until recently that they have felt empowered to really do something about that and felt like that is part of what's in their lane of work. And there are a few reasons for that. First and foremost is kind of the broadening of how we understand care management. So most Medicaid agencies think about social determinants of health in the context of the care management that they are trying to provide for their beneficiaries, and at a very high level thinking about it across three different buckets of patient populations. First and foremost is really taking care of the immediate health needs of patients with complex care needs. The linkage between social determinants and the care that Medicaid agencies need to provide those patients is really what comes foremost to mind. But they're also thinking about it in the context of trying to manage care better for those individuals who may be on the cusp of having becoming a patient with complex care needs, and really trying to prevent that from happening. And then finally, thinking about these investments in the context of upstream investments for healthy kids, healthy adults, with the intent that those investments will pay off in the long term. But I would say primarily the focus really is around the patients with complex care needs from the Medicaid perspective. So why are Medicaid agencies, why do Medicaid directors, now see social determinants as part of what they can undertake? And I think there are two main trends that we see that are really driving this kind of broadening of perspective and willingness to incorporate social determinants into Medicaid. First and foremost is the uptake of value-based payment and advanced care models. So with that shift, and that is something that all Medicaid agencies really across the country are prioritizing, that there's now a business case for incorporating social determinants and really thinking outside of healthcare delivery to better manage the care, improve the quality, and at least contain the cost growth of these populations. And so there's now a business case context in which this can make sense, whereas it didn't necessarily in the context of fee-for-service, because there was no claim associated with these services. So that's one. And the second is just the signals that Medicaid directors have been getting from the federal government around this issue. Back in 2016, when the revised Medicaid managed care rules were rolled out, there were some provisions within there that clarified health-related social needs, value-added services really can be seen as part of care management, particularly some of the referral, identification activities. Those are really part of care management and what a managed care organization can be providing and can be including and using their capitation dollars to cover and can be included in the medical loss ratio. So that was important. But then we're also getting comments even from CMMI and CMS now that they're looking at social determinants and really trying to think about how they can, in their federal regulatory authority, what Medicaid agencies can do to cover services beyond simply the Medicaid managed care context. So just those signals, I think, from the federal regulators are worth noting and really are enabling state Medicaid directors to think more broadly. So I'm sure you're probably all familiar with this, since this came from the National Academy of Sciences work on the social determinants, but I just wanted to pull it up because I think it's really helpful, both from the work that I do with Medicaid agencies around helping them think about where they want to use their policy levers, what types of activities they feel like they want to help either the managed care organizations or the providers invest in. I also think it's really a helpful context for thinking about the future of any workforce in this social determinants of health work. Where are nurses best able to play a strong role? And even within these very broad categories, where are nurses, what plays to their strengths? And how does that complement what may be going on within other workforce areas? I'm not going to belabor what this is because I think you're probably all familiar of what these different categories are. But I think it's just helpful in framing up a little bit about how Medicaid's thinking about this and implications for nursing. I'm not directing this in the right way. Thank you. Okay, so how is this all playing out in Medicaid? So the Center for Healthcare Strategies worked with the Association of Community Affiliated Plans to conduct a thorough assessment of how Medicaid agencies, one, are using their authority under Medicaid managed care to advance social determinants of health work. 40 out of the 50 states have some form of managed care, and about 80% of the Medicaid beneficiary population is covered through a managed care plan. So that's one of the big levers that Medicaid directors use to try to advance any type of care transformation work, including social determinants. We also looked at the 1115 waivers, 25 1115 waivers that involve some type of care delivery transformation reform to really understand how Medicaid is using two of those main levers. And even within those, there are levers like payment reform. That has been a huge lever for social determinants of health, care management requirements. And so here, there were a lot of findings. You find a lot when you scan 40 state Medicaid contracts in depth, looking for social determinants of health, and we found a lot, which was good. But I just wanted to highlight a few key takeaways that we have found, and because I think it sort of shows how this is playing out and where Medicaid is putting some of its emphasis, at least for now, because this is likely to evolve over the next 10 years. First and foremost, where the most energy is right now is around screening and referrals. So that assessment and assistance buckets of social care activities. 35 states are incorporating those specifically and explicitly into their care management requirements. So as the managed care organizations work with their care management staff, they are now challenged to embed things like screening, referrals into those processes. But states are not only looking to their managed care organizations to do this work, they're also filtering those down into their care delivery requirements around delivery system and payment reform, that they are then filtering down to providers. So patient-centered medical homes, accountable care organizations, all of those are not just a payment model, but they come with care management requirements. And so within those, states are beginning to embed these types of social needs activities into those requirements as well. So it's really happening at both the MCO and the provider level. And then finally, I'll just note that 7 of the waivers, I would say in all the managed care organization contracts, there's some language around partnership and partnering with community-based organizations as part of this work. I would say it's pretty loose and pretty, it's a soft lever, I think is the terminology that we typically use when thinking about the language. But where we really are starting to see the rubber meet the road is around waivers and states using the waivers to provide additional funding for these partnerships with community-based organization, that alignment piece of the social determinants of work. I'm not sure if I'm just doing the wrong. There we go. So how is this all playing out? What are the managed care plans actually doing, both in response to those, but also just because they have incentives to do a lot of this work? And really, again, we see most of the energy around at least for now, around the assessment and the assistance buckets. So linking members to services, creating a directory to understand what services are available in the community to then be used either with the frontline care managers and provider offices, or more likely with the care managers that are embedded in the managed care organizations. There's increasing use of community health workers. In the work that we do with state Medicaid agencies, there's widespread recognition that health workers have a really important role to play in social determinants of health, in care management, and really providing a helpful, important linkage, especially in Medicaid and the enrollees that Medicaid serves. So that's just giving you a feel for what are managed care organizations actually kind of doing as a result, again, at a pretty high level. Okay, so what does all this mean for nursing? What are the implications, particularly from a nursing perspective? And so here, just I will say I'm not a nurse. Again, I work with Medicaid agencies who typically are pretty hands-off when it comes to who does what in the provider offices, who does what in managed care organizations. Medicaid agencies are pretty aren't very prescriptive when it comes to that. But I think a few implications for all of this for the future of nursing. First and foremost really is the emerging need and appreciation for more and reward for more holistic approaches to patient care. And the fact that nurses are very well positioned, both in their training and their work, to really have that vision and have that perspective and really being able to bring that to bear. Second is the need for leading, training, and supporting the multidisciplinary care teams that are now going to be charged with incorporating social needs into their workflow. And we're beginning to see, we've known for a long time, changing anything about workflow is challenging, but then bringing this non-clinical perspective into the care teams, overseeing that, motivating your staff, helping them figure out how to do that in the least disruptive way, that leadership piece is really critical. Second, and probably related, is just leadership in care management, being able to take that broader view of how all of these pieces fit into the care management flow, both, again, at the managed care organization and within the provider setting as well. Facilitation of partnerships. Having a person who really is able to navigate the language and the cultures of both the healthcare organization and community and social services organization. That linkage, that person who is able not only to kind of talk that language that both sides understand, keep the commonalities of mission central to them, and really be able to navigate that both in terms of creating partnerships, but then helping to operationalize those partnerships. That's a huge need, and it's an area where I think both MCOs and providers are struggling to figure out how to really partner effectively with community-based organizations. And then finally, Medicaid investment in primary care. In the work that I do, even beyond social determinants of health work, there's an increasing recognition that Medicaid really needs to figure out how to reallocate resources out of acute care into primary care. And so states are beginning to set thresholds of how much capitation payments go to primary care. They're really trying to think thoughtfully about how to move that and be more explicit about that. And then finally, just a note of caution, because I think there's a lot of optimism and excitement. It's just the fact that remembering that all of this really is taking place in the context of the drive for value-based payment and contracting. And that this is not happening in a context where Medicaid is spending more money. This is still in the context of really bending the cost curve and keeping it moderated. And so there will continue to be pressures on the need to keep costs low and to use workforce that has a lower cost profile. So those are, some countervailing winds that I think folks need to contend with as a result. So with that, I will thank you and look forward to our discussion.
Thank you, Tricia. And Angela, I'll welcome you up to the podium.
Good morning, and thank you for the privilege of being before this prestigious committee and for the opportunity to share the work of CVS Health and the organization's nurses. Okay, great. There are a variety of trends driving change in the healthcare landscape that are influencing our direction and practice. First is the expansion of consumer-directed benefit designs, empowering patients to have a more active role in their health. And as they've become more accountable, they've placed a particular emphasis on increased convenience and cost transparency. They also demand a healthcare experience comparable to other aspects of their daily lives. Consumer conceptions of care have also changed. It's not a binary feeling of health or sick. Consumers are pursuing preventative care and wellness options that allow them to lead their fullest lives. This includes actively seeking solutions to improve their physical, social, and emotional well-being. With an aging population and the decision of many seniors to age in the comfort of their homes, there's a greater need for providers to extend age-friendly care and support. We're also seeing the evolution of personalized care with a greater recognition that one size does not necessarily fit all patients. Advances in technology and the proliferation of personalized data through the increased use of genomics and wearable technology have made analytics an important complement to the provider's healthcare decision-making, as well as the need to move towards holistic, whole-person care to improve health outcomes. And lastly, the continued evolution of payment models is driving the need for delivering on equality outcomes while working to lower the overall costs of care. At CVS Health, our integrated capabilities power a surround sound consumer healthcare experience that serves as a complement to the broader primary care-based, community-based health system. Our work is focused on creating consumer-oriented solutions and making investments in our assets, capabilities, and partnerships to help consumers navigate a fragmented, complex system and to allow us to develop integrated healthcare solutions. And nurses are an important part of our work. Across the CVS Health Aetna organization, we have more than 10,000 nurses, including NPs, RNs, LVNs, LPNs. Our nurses work in a variety of roles, ranging from corporate leadership roles to those directly supporting clinical care at MinuteClinic, Quorum Infusion Services, or our specialty pharmacy businesses, as well as nurse care managers who support patients at Accorton, Aetna, and Omnicare. An important area of our work where nursing plays an important and significant role is within our retail healthcare division, MinuteClinic. MinuteClinic, for a number of years now, has been continuing to deliver on its purpose of providing convenient access to affordable quality care in our communities. Today, MinuteClinic nurse practitioners and PAs deliver care across 1,100 clinics that span across 33 states and D.C. Today, the presence of MinuteClinics across our country places more than 50% of the U.S. population within a 10-mile radius of a MinuteClinic. Care is delivered by NPs and PAs who deliver evidence-based care that is delivered with compassion. They deliver care 7 days a week, evenings, weekends, holidays. In fact, the majority of our patients are seen during off hours. We are Joint Commission accredited and have been so since 2006 and have a deep commitment to data exchange and interoperability to ensure communication across our community partners and care providers. And we maintain an intense focus on delivering quality care and that meets our goals for patient satisfaction. As an organization, we have some very focused priorities for how we want to impact care and promote nursing. First, we believe that it is important that we be local and that we are engaging people with the care they need, when they need it, where they need it. We strive to make it simple. We're working to make a complex system easier for folks to understand, to access, and to consume. We are striving to improve health. We want to help people achieve better health and at a lower cost. And we constantly strive to lead the change by challenging the status quo with technologies, innovations, business models, and partnerships that can accelerate change and help us achieve our goals. We find partnerships and opportunities to help us as an organization address social determinants of health in an effort to close the gap on health disparities within our communities. And we are committed to delivering quality care that's grounded in evidence-based medicine. Lastly, we want to enable and ensure the empowerment of the healthcare professionals who work for our organization, especially nurses, to practice to the top of their education and training, to deliver whole person care that fulfills our purpose to help people on their path to better health. At CVS Health, our community-based assets are key differentiators that enable us to transform and dramatically improve the consumer health experience. They give us tremendous reach, engaging with about 1 in 3 Americans every year. This reach allows us to meet patients where they are, in the community, in their home, or even in the palm of their hand through digital devices. We believe that we have an unparalleled community presence. We have nearly 70% of the U.S. population living within 3 miles of a CVS pharmacy location. And being local enables us to become part of the consumer's normal, everyday routines. We can leverage the frequency of these consumer interactions to build our programs and services into their existing routines, their everyday lives. We also build upon our existing programs and establish relationships to extend care to the consumer's home. We've made great strides in this regard through our expanded prescription delivery program, our Quorum infusion services, and through our Aetna nurses and other care team members. In total, we provide about 700,000 visits to patients in their homes and community settings annually. And we're also increasing the support that patients can receive through our digital properties. Just one example, today more than 72 million of our CVS Health customers are enrolled in our text messaging program, which allows them to receive real-time alerts about their services. This local reach enables us to impact social determinants of health, and a couple of national programs that we've implemented across local communities to do just that include Project Health, which is a program that offers underserved communities no-cost, comprehensive health assessments, including blood pressure, BMI, glucose, total cholesterol screenings, and with the intent of detecting early risks for chronic conditions like diabetes and hypertension and heart disease. Since it was founded in 2006, Project Health has delivered more than $127 million in free healthcare services to nearly 1.7 million Americans. A second program has a focus on addressing housing insecurity in key markets. CVS Health is making significant investments totaling more than $50 million by the end of this year in affordable housing across the country to help provide support for underserved and at-risk populations. In the past 7 months, CVS Health and Aetna have closed on commitments to invest more than $40 million in affordable housing that will construct or rehabilitate over 1,600 affordable housing units in 19 communities across 6 states. These investments include more than 100 permanent supportive housing units reserved for people requiring mental health service, are homeless or at risk for homelessness, have HIV/AIDS diagnosis, substance use disorder issues, or have long-term chronic health conditions. In addition to developing these housing units, the company and its investment partners are working with community organizations to provide services such as independent living skills, cooking and nutrition, financial literacy, health information classes, resident outreach and engagement, client-centered treatments, as well as social support. The practitioners at MinuteClinic as well are helping to support care across our communities. Certainly, first and foremost, by staying true to its purpose in delivering convenient access to affordable quality health care. In addition, MinuteClinic nurse practitioners treat a broad range of conditions from acute to chronic care, as well as offering preventative and wellness services such as vaccines and biometric screenings. Our nurse practitioners are expert at supporting patient understanding of their illness, as well as supporting lifestyle modifications such as tobacco cessation, an area that across CVS Health we're deeply committed to. We're also committed to supporting communities with, by providing a lower alternative option for care, helping to avoid emergency room care for conditions that can safely be seen in a community-based setting. Our care is evidence-based and supported in our electronic health record and clinical workflow guidelines. We meet or exceed HEDIS and STAR measures and have a focused priority on supporting the goal of closing gaps in care. With permission, we share records of clinical progress notes with the patient's established primary care providers and support those patients. About 40 to 50% of the patients we see at MinuteClinic report not having a primary care provider. And in those instances, our practitioners work to support identifying and close gaps in care, as well as reestablish or establish connections into the broader primary care-based health system. Since inception, MinuteClinic practitioners have cared for more than 48 million patients. I think this is, sorry, I'm just making sure the slide is right. Okay. One way that we're also working to advance our work at MinuteClinic and support our communities is the advancing of the scope of service of MinuteClinic practice, enabling and supporting MinuteClinic practitioners, again, to practice to the top of their education and training. Moving from acute, historically acute episodic transactional care to care that is holistic, patient-centric, identifies gaps in care, and hopes to then works to connect them to the broader primary care-based health system for ongoing support. We've moved from the assessment and care of acute minor episodic illnesses and injuries to the assessment and treatment of chronic care conditions such as high blood pressure and diabetes, as well as supporting aging populations through some work we're doing with age-friendly health systems, as well as a young adult population, advancing our scope of service in areas including sexually transmitted infection assessment and treating, as well as contraceptive care. And we continue at CVS Health to build upon this approach. We're continuing to work to transform the consumer healthcare experience with our new Health Hub locations. In our Health Hub locations, we've curated a customer-focused healthcare experience that will help improve chronic disease management and provide customers with a convenient and compelling destination to manage their overall wellness, from sick care to self-care. Health Hub is a first-of-its-kind community-based store concept focused on helping customers get well and stay well by offering a broader range of healthcare services, wellness products and services, trusted advice, and personalized care, all with the ease of walking into your local CVS pharmacy. A quick highlight of what you'll see inside our Health Hub includes new front store products, particularly in the area of health and wellness, durable medical equipment, diabetes supplies, for example, new health services, advanced pharmacy care, as well as expanded MinuteClinic services, particularly in the area of chronic conditions, including diabetic retinopathy screening and end-to-end solutions for obstructive sleep apnea. And for customers who wish to manage their care from the palm of their hand, Health Hubs will offer access to digitally enabled health and wellness apps and connected health monitors and smart devices, making the experience of achieving your best health easier and more achievable. Expansion of the Health Hub is based on the success of 3 pilot locations in Houston, Texas. And at our Analyst Day this past June, CVS Health announced its expansion plans for Health Hub locations through 2021 to include approximately 50 more by the end of this year, with up to 1,500 Health Hub locations in operation by the end of 2021. Sorry. This slide here just represents some examples of patient journeys through our Health Hubs, and at a high level what it denotes is patients coming into our Health Hub locations with specific healthcare needs, and our MinuteClinic practitioners identifying other gaps in care, closing those gaps in care, working with patients to address their healthcare needs while reestablishing care within the broader community and the broader primary care-based health system. In addition to care transformations through our Health Hubs, we are continuing to use our technology and digital capabilities to increase our access and reach, delivering high-quality, low-cost, and convenient care through MinuteClinic video visits. The goal of this program is to expand reach of MinuteClinic practitioners to provide convenient, affordable access to high-quality care, make our services more readily available. Today, MinuteClinic video visits are available across 40 states, and they are available 24 hours a day, 7 days a week, 365 days of the year. A few additional highlights to share relative to nursing practice, NP practice, and the work and focus of our organization, particularly at MinuteClinic, is our work with age-friendly health systems. At MinuteClinic, we identified that we had opportunities to do more to improve quality care and improve health outcomes of our senior patients. And with that in mind, we partnered together with Case Western Reserve, the Francis Payne Bolton School of Nursing, as well as the Institute for Healthcare Improvement, and received an age-friendly health system ambulatory care continuum planning grant with the John A. Hartford Foundation. And with this planning grant, we are working to develop a training program for all of our MinuteClinic providers in the 4 M's of age-friendly healthcare delivery. We also remain committed to our Joint Commission accreditation, understanding that the delivery of quality, safe healthcare is foundational to our purpose and essential to our continued work to advance healthcare delivery across our communities. And lastly, as an organization, we understand and believe that our commitment to a quality patient experience begins with a quality nurse-colleague experience. After multiple years of working to create a culture of nursing practice excellence, this past September, we received designation as the very first retail healthcare organization to have achieved ANCC Pathway to Excellence designation, and believe that this is essential as we support our nursing workforce to support the care of those we serve across our communities. Thank you.
Thank you so much, Angela. And I think we're going to have Elizabeth now join us by Zoom.
Hi. Thank you for having me, and thank you for accommodating my remote participation.
Welcome, Elizabeth.
Okay.
Yes.
Sorry. And it is still dark here, but I am really honored to be here. And appreciate the work you're doing. I served on a NAM panel, and I understand both the importance and the impact. I did, however, question being invited because, to be honest, our members haven't focused as much as one might think on. Sorry, I'm seeing that there's a bad echo. Hold on 1 second. Is this any better? Sorry about that. Should I continue, or should we work on the echo?
Yeah, we're not hearing an echo, so if you would, and we'll work on the technology. Thank you, Elizabeth.
Okay, terrific.
You're clear as a bell in Geneva.
Excellent. Well, then I'm going to keep going. So what I was saying was that I had questioned my participation because this has not been an area of focus for the large employers whom I work with. But that was actually considered sort of an important point of view. So I'm happy to share what I can. I represent about 40 large employers, jumbo employers, and we spend collectively about $100 billion a year on healthcare, and we are representing about 15 million Americans or more. So this is not a small group. It is really a significant effort to address healthcare challenges. So I need to start with a couple of disclaimers, though. Employers are not monolithic. We have some employers who are deeply invested in social determinants, for instance, and some who really don't see it as their area of focus. But most importantly, healthcare is not these employers' day job. They build airplanes. They sell groceries. Their day job is not fixing the healthcare system, and yet they are increasingly expected to intervene and do something to address cost, quality, and outcomes. I will say that most of our members, our employer members, really expected the healthcare system to do that. They expected all of the partners that they pay handsomely to take on health outcomes, quality, and cost effectiveness. They have relied on health plans, on vendors, and on other partners to really do this. But they are increasingly aware that after 30 years, the healthcare system has not fixed itself. And their strategies of relying on those partners are starting to change, and they are increasingly looking to intervene much more directly in the healthcare system. Can I just ask, should I wait for the echo fix, or should I keep going?
I would say keep going. We're working on it here, but if you could keep going, Elizabeth, thank you.
Okay, sorry about that. So we know that we know this is important. We know that we need to fix healthcare at the community level. We know that employee health is a top priority. But it is also very difficult for employers and benefit leaders to really address it at that level. When they are purchasing healthcare benefits, again, they have been reliant on health plans and other partners to do this work. And it really hasn't been in their budget or in their portfolio to get into what is happening on the ground or get into who is doing what. That said, they have immense respect for clinicians, for physicians, for nurses, for the social workers. They want to partner much more directly with those providers to help achieve what we know are shared goals. Some of the things that employers are working on, what our members are doing as they have increasingly looked to intervene. One example are our centers of excellence. So we have very large employers who have absolutely understood that healthcare quality varies, and they are leading with quality. They are not looking to just address price. They believe that investing in the highest quality care will actually achieve both better outcomes and lower cost, which is really what they're aiming for. And our Centers of Excellence program has actually proven that. So they have identified, many of our members, working with our TPA partner, Health Design Plus, have identified some of the top performing surgeons in the country, and they have implemented a travel program for certain conditions like spine or joints or bariatric. And some of the early results, which have been quantified, there's an article in the Harvard Business Review about Walmart's results. They're seeing up to 50% reductions in readmissions. They're seeing significant reductions in infections or adverse events. And because they are avoiding some of the quality challenges, they are also seeing dramatic savings in total cost. One of the reasons that this is working is because they have designed alternative payments. In this case, there's a prospective bundle with a warranty. They understand that paying differently is going to be necessary for different outcomes. And they are looking for those partners like TPAs who are nimble enough to implement these new models. Another strategy that our members are deploying increasingly are on-site clinics. Disney and Apple and others have been doing this for several years, and you may have seen recently Walmart is piloting new clinics. And these are not traditional primary care clinics. They include nutritionists, they include dentists, they include behavioral health. All of those contributors to whole person health are appreciated and recognized, and yet they haven't been able to find them adequately in the healthcare system, so many of them are taking this on and designing them themselves. We have also designed and are piloting maternity bundles that are much broader in scope. So they include home visits, they include a year perspective. So we are looking at new ways to pay for care that incents and supports that wraparound whole person health. We are also working collectively in California on a new payment model for advanced primary care. We run the California Quality Collaborative. Their results in improving health, avoiding unnecessary admissions, addressing social determinants, we have quantified that advanced primary care and that investing in stronger primary care achieves better health at lower cost. So our members are very committed to supporting that, to paying more for primary care, but also to pay differently and to really use measurement to help identify what we would like the system to be accountable for. So patient-reported outcome measures, functional status, healthy days, and other indicators of behavioral health. There is a growing expectation that those will be the metrics on which payment is made. We do also understand, though, the barriers in reporting and even collecting those measures. We have not, as a country, developed the data infrastructure or the systems or processes to really collect the data that matters to purchasers and patients. So we are also involved in that. Another area in which our members are working surprisingly aggressively is direct contracted ACOs. Over 10 of our members are directly contracting with ACOs who they are understanding are taking accountability for total health and total cost. And direct contracted primary care. There is a growing willingness, again, even though this is not the employer's day job, to really take this on. And this is not your usual suspects. We have Microsoft or Intel or some of the tech companies that are really recognizing that they simply have to take a more active role in assuring their employee health, are looking for these new arrangements with their healthcare partners. And again, I want to underscore there is such an interest in partnering more directly with clinicians, with nurses, with the care teams who are doing this work, that is an area that we are continuing to explore. There is a recognition that payment will have to change. We know that without population-based payments, that there is not going to be adequate investment in addressing the social risk factors and meeting social needs. We heard earlier about the Medicaid programs. We think that the Medicaid waiver programs are actually an example of what can work, and we are looking to learn from and partner with other payers. So we understand that there has been an enormous amount of work on the ground to do this. Unfortunately, what the experience is from the employer side is dramatically increasing costs. We know that employees the average premium is over $20,000 a year. And when you're talking about a $15 an hour worker who is increasingly expected to shoulder a larger portion of that cost, this is becoming it's simply untenable. So we are increasingly engaging much more directly in what our members have called really designing the healthcare system that we would be proud to buy. So we are grateful for your work. We know that you are improving the experience and outcomes of our member employees daily, and we are very grateful for that. And we look forward to partnering with you and learning from you what works and how we can do this best together.
Thank you so much. So you'll be able to stay with us, Elizabeth, huh?
Absolutely.
Wonderful. Thank you so much. And now Priya and Robin are going to go back and forth and help us to see this last bit here before we open it up for discussion.
And they are putting patient experience at the center of what they do by developing new models of care and embracing new strategies to improve value and health equity. As you know, and as we've talked a little bit about already today, the field is moving towards value. I don't know how to change these slides. Okay, they're moving to value. And while there's no standard definition of value across the healthcare field, the AHA is taking a broad approach with the goal of capturing what individuals actually get for each dollar that they spend on healthcare. So that includes looking at costs, outcomes, and the patient experience. And many times when people think about value, they jump to alternative payment models or models that are tied to what you're getting paid for or incentivized to do. And hospitals are taking that on. So as you can see here, more and more hospitals are participating in alternative payment models each year. This slide actually shows the combined participation of hospitals over time in accountable care organizations, medical homes, and bundled payment programs. In addition to those programs, hospitals are taking on more risk with commercial payers, and the number of hospitals contracting with commercial payers where their payment is actually tied to quality metrics is increasing every year as well. But hospitals' value-based efforts aren't limited to only these areas where they're getting payment. Hospitals around the country are implementing a broad variety of strategies in these 4 areas. So this includes efforts to improve care coordination, manage chronically ill patients, reduce clinical variation, and implement process improvements that reduce costs. It also includes efforts to address disparities and improve health equity. And many of those strategies that our hospitals are focusing on address the social needs of their patients and the broader social determinants of their communities. They are making sure that individuals have the resources they need to achieve health, which is why we're here today. So we have seen hospitals around the country start to take this on, and we've seen an increase in the number of hospitals that are screening patients for social needs. Data from our most recent population health survey shows that 77% of hospitals are screening some or all patients for social needs. And they're screening for a number of different areas, the most common being health behaviors, housing, and food insecurity. In addition to screening, hospitals are developing programs to address these social determinants of health and social needs. So you will see that the highest number of programs here focus on health behaviors, which include exercise, smoking, and healthy eating. There's also been a significant number of hospitals providing transportation for patients to increase access to care, and a large number of hospitals implementing programs to address food insecurity, social isolation, and education. But hospitals cannot and are not doing this alone. We heard earlier about collaboration, and in fact, 91% of hospitals who responded to AHA's annual survey are partnering with at least one other community stakeholder to address the social determinants in their communities. So hospitals are no longer just acute care facilities. They're taking on value in a number of ways. They're addressing health equity, they're addressing the social determinants, and they're focusing more and more on health rather than health care. So as they transform, the role of nurses who work within hospitals and other settings is also transforming. So I'll hand it over to Robin to discuss some of the ways nurses are working on this.
Okay. Good morning, everyone. I feel like I'm here providing color commentary. Nurses, why, so again, the slide, sorry about that. So why nurses? Well, we're here today to talk about nursing. Nurses are not only the most trusted profession as identified by Gallup for the past 17 years, I know we've all heard that statistic, but just last month, Becker's reported that nurses are most trusted to improve the U.S. healthcare system. This was according to a survey of consumers conducted by the New York Times, the Commonwealth Fund, and the Harvard T.H. Chan School of Public Health. Nurses are educated to use the systemic guide we call the nursing process. So assessment, diagnosis, planning, implementation, and evaluation is the framework that we deliver care. And this is the science of nursing, as those of us in the room that are nurses know. And we blend that exquisitely with experience and compassion, the art of nursing. There are many definitions of nursing, but almost all of them include the promotion of health, the prevention of illness, care of the ill, disabled, and dying, care throughout the lifespan. Advocacy, promotion of a safe environment, research, participation in health policy, and in patient and health systems management and education are only some of the key roles that nurses participate in. And this, I want to give credit to the International Council of Nursing. That is, partially their definition. As we heard earlier, nurses are not just practicing in hospitals, but also in homes, schools, community centers, outpatient care facilities, clinics, in industry, and according to the Bureau of Labor Statistics in 2016, 61% of our nurses are employed in hospitals, and that will be repeated in the near future, that survey that they do. So the nurse's role in addressing social determinants. Nurses are educated to assess the totality of a person, the holistic approach that Tricia and Angela mentioned earlier, not just the clinical needs. We are acutely aware of the impact of social needs on a patient's health and well-being and are expert navigators, as has been discussed earlier. The concept of continuum of care is one that nurses have a deep understanding of, and as we see this as nurses function in a traditional care management or case management role, but also Priya will be giving some specific examples of creative roles and case studies. So that will be coming in the next section. We are no longer functioning in the discharge paradigm. Rather, transition is the lens that nurses are using to view our patients, our interactions, and our interventions. We need more research in this area. As we spoke to nurses and nurse leaders, this was one of the really clear messages that they shared with us. So now I'm going to hand it back to Priya for some specific case examples. Oops, sorry about that.
That's okay.
I'm going to see if you can do that. That's not working. There we go.
So I think Elizabeth shared that her members are not monolithic, and neither are hospitals, and the ways in which they're addressing social determinants are not standardized in any way. We are seeing them take on different types of social determinants in different ways, and in ways that align with what their communities need. So by nature of aligning with what their communities need, no two communities' programs may be the same. So what we wanted to do today was share some of these programs we're seeing around the country, how nurses are involved in those programs, and the results in terms of cost and outcomes and patient experience that they are seeing as a result of these programs. So we'll start with some that are in the inpatient setting, and then we'll move to other sites of setting like home and in the community. So starting with in the hospital, ProMedica Health System in Toledo, Ohio, has nurses complete a nurse assessment for every inpatient admission. And that nurse assessment questions patients on 10 different social needs. Based on how the individual responds to those questions, the nurse is then responsible for triaging the patient and either getting them to an inpatient social worker or care navigator or sending them out to the community to a community navigator hub that they've developed with partners in Toledo. To date, they've screened over 24,000 patients, let me start over with that. In 2019, they screened nearly 24,000 patients, which is a huge jump from just 2 years before when they screened 5,000 patients. So they are doing this at scale now across ProMedica Health System, and about 1/3 of the patients that are screened have screened positive for one or more social need. So when that happens, they are getting them the resources they need. Another example is at Baylor Scott & White Health, and their nurses aren't just involved in the actual screening process, but they have a program where nurses are training community advocates. So they're just volunteers in the community that want to come in and help. They're training community advocates to do the screenings and to make the referrals to community resources. Baylor Scott & White's program has seen really great results in a short amount of time. To date, they've screened almost 2,000 patients, but they've been able to see their 30-day readmission rates for those patients drop by 87.5%, which is significant. Another example, and this one is from a rural hospital in Nebraska, just to show that this can happen in all communities around the country. Their interdisciplinary care teams, including nurses, social workers, pharmacists, and clinical therapists, huddle 2 times a day to discuss the needs and progress of each patient. As part of that huddle, they also conduct a risk assessment to identify patients that are most likely to be readmitted, and they examine patients' social needs. They've been able to reduce readmissions by 42%, and in just 18 months, they were able to save over $800,000 by having those 2-a-day huddles across care teams. So now if we look outside of hospitals themselves, Sharp Healthcare is doing a number of different things. One of their great programs is the Transitions Program, and they provide 24/7 home-based palliative care for patients with advanced chronic illness. They're a team of doctors, social workers, nurses, and spiritual support advisors visit patients in their home. They assess social needs and connect patients to the resources they need. They've been able to cut hospital admissions in half, and for those that do have to be admitted, their length of stay has decreased by over 50%. So those are some significant results. They've also seen significant changes, and those have varied based on the condition in which the patient is living through. Another example is Boston Children's Hospital, and they developed a program to help children in their service areas that are suffering with asthma. We've actually seen a lot of asthma-based social determinant programs across the country. Here, nurses and community health workers provide asthma care management, education, and they actually go into the homes to see the living conditions and address things. So how can you launder sheets? Is there mold in the home? They're addressing all of these different types of things for these patients. As a result, they've also seen significant results. ED visits have decreased by 58%, and their admissions for the patients participating in these programs has decreased by 80%. So these programs and the work nurses are doing to address social needs are leading to real results. And we also have really great examples outside of just nurses being part of the process of nurse leaders who are taking active roles in innovating and coming up with creative programs to address the social determinants and social needs of their patients. So a couple examples of that, just so you can get a flavor of what nurse leaders are doing in their roles. One program is the Johns Hopkins School of Nursing Community Aging in Place, Advancing Better Living for Elders, or the CAPABLE program. Some of you may be familiar with this one, but it pulls together a team of a nurse, an occupational therapist, and a handyman to go into individuals' homes to address their social needs in the context of their holistic care. That program has seen more than a 6 times return on investment. So they estimate that roughly $3,000 in program costs yielded more than $20,000 in savings. Another one is Regional One Health in Memphis, Tennessee. That program, they created a program called One Health that was designed and spearheaded by 2 nurse leaders who are actually pictured on this slide. A nurse leader continues to oversee that program, but this program addresses the social needs of Regional One's chronically underinsured population. A team of nurses, social workers, and community organizations provide behavioral health, social services, and employment support to these patients as needed. In just 2 years, they've reduced ED visits by 66% and inpatient admissions by 78%. In total, just in 2 years, they've been able to save $8.3 million in cost. Another one which I thought was really unique, it was Rush Oak Park Hospital in Chicago, Illinois. They actually had a task force of nurses come up with a way to take the food waste that was happening within the hospital and partner with community organizations that were serving individuals in Cook County that needed access to food. And so now they take the food that would otherwise be wasted in the hospital, they package it at the end of every day, and they deliver it to the community organizations in which they're partnering with to make sure that those people have access to food. So it's a win-win for the hospital and for those facing food insecurity in the community. In just a short period of time, I think since 2015, they've donated 20,000 meals to homeless individuals in Chicago. And then we have 2 more, which I'll go through very quickly. I realize we brought a lot, but I wanted to really give you a flavor of what's happening in the field. Another example, and this is an asthma clinic as well, on the south side of Chicago, created by the Urban Health Initiative. This is a bit different than the one at Boston Children's, so the nurses aren't actually the ones that are going into the home. Here they use community health workers and social workers. But this one is unique because it is a nurse that has created the program from the start. And using her nursing background and her focus on data and outcomes, they've been able to drive really, really great results in a short period of time. So like the other asthma programs, they've seen significant reductions in ED visits, hospitalizations, missed days of schools for children with asthma, and missed work days for their parents. And then the last one I wanted to highlight is El Rio Health in Tucson, Arizona. Now this is a group of FQHCs, so it's not a hospital, but we thought it was important to bring it to your attention because the CEO of El Rio Health is a nurse. And she has created a number of programs around social determinants, one of which we've highlighted here, which is their RN care management program. Nurses serve as a point of contact. There's a 24/7 hotline. They are going into homes when patients need it. They are there for the patients in the community. As a result of this care management program, there's been a 28 to 30% reduction in hospital readmission rates across their FQHC population. So those are just some examples, and I'll let Robin close it up.
Okay, so thank you, Priya. So one final slide. We could also label this slide implications for nursing. So embedding social determinants of health into the nursing curriculum is really key. Work is ongoing with AACN, the American Association of Colleges of Nursing, and AONL, my organization for American Organization for Nursing Leadership. We've had a committee that's been working on an ongoing basis, and most recently we met for a day of dialogue in October. One of our strong recommendations is that we align the work that AACN is doing around the domains for nursing education with the practice competencies. So there, when possible, there's really a continuum of learning and practice. Education must also include the concept of cultural humility and include experiential learning in traditional and non-traditional settings like the ones we just learned about. A culture of innovation. Really, this needs to be the mindset for the entire interprofessional team. We need to think that way in our educational institutions as well as our practice settings. Encouraging empowerment and critical thinking is really so important to, to the health of our community. And time, I have this, and we've all heard this, I guess this little cliche, but perfect is the enemy of good. We need to move on these concepts. One of the things that we talked about at that day of dialogue in October, the nursing student who will be entering a nursing program in the coming year may very well practice until 2070. That's an amazing thought to me. Think about that. That's really, what will the world look like in 2070? We need to invest in our educational programs. The ROI of the programs that Priya outlined suggested the magnitude of the impact that nurses can have in financial terms, as well as, of course, quality of life. So we need to make sure that our nursing students, our new nurses, have the skills they need to be able to practice in settings and in programs like, that were described. And I guess finally, scope of practice and licensure regulations across states need a look. We really need to examine them. One brief example, the National Council of State Boards of Nursing report that 54% of RNs provide nursing services using telehealth technology, with 45.7% providing these services across state borders, compared to not 39% in 2015. So in 2 years, that really jumped rapidly, and that was from a 2017 workforce study. So when it's, the study is redone this year, it will be very interesting to see what the statistics show. So in conclusion, we would like to thank you very much. We are very honored to be invited to participate in the panel today, and we really look forward to the dialogue.
Thank you. I'm so excited. I feel like I'm seeing the future of nursing here. The presentations were amazing, and I think it really does, each one of them, speak to the IQ of nursing, bringing the clinical and the operational knowledge, also the EQ, the empathy, and the CQ, the curiosity quotient, and really looking outside the traditional walls to think about the future of nursing. As you may know, a lot of my work is typically outside the United States, and what I'm seeing there is that our CQ should reach outside the walls to really bring in some of the models that demonstrate our work on our charter, like creating the voice of patients and families. A few years ago, I gave a talk in Paris, and I gave a challenge to the 4,000 people in the audience, and I said, when you go back to work, pick up on Susan Edgman-Levitan's challenge and not only ask the next patient, what's the matter? Ask them what matters to you. And a nurse in a pediatric hospital in Scotland took me up on that challenge. She went back to her hospital and asked the next patient, not only what's the matter, but what matters to you. The girl was a 7-year-old girl, severely autistic, and had never spoken. So the nurse, Jen Rogers, gave her a piece of construction paper and an art kit. Now, that's my Boston accent coming through, A-R-T, crayons. And so they drew a poster, which they put on her wall, and it described her what mattered to her and to her father. And her father, who's her only caregiver, had a cardiac event that evening and was taken to the adult hospital in Glasgow, and Kendra was by herself. But because that poster was on the wall, the doctors and nurses said they knew how to take care of Kendra. That then spread across all of the hospitals in Scotland, and the culture there is on every whiteboard that the patient says what matters to them. Recently, Jen Rogers, that nurse, was named the Scottish Woman of the Year, not just in healthcare, the Scottish Woman of the Year for the change that she was able to make across the boundaries of healthcare. Another nurse who was at that same meeting, Anders Vege from Norway, also picked it up. And he said, this needs not only to change the way we take care of patients in Norway, although he did that, but he also launched What Matters to You Day. And this is changing the culture in 30 countries. Last year, 23 million tweets. People are talking about this not only in reaching out to patients and families and saying what matters to you, but to each other. And it's changing the way we're building teams. Anders and his work and Jen in her work have changed the culture from one little test across the world. There are nurses in Sao Paulo, Brazil that I visited recently who said, we know how to take care of patients. We know which patients have social challenges. The social determinants are going to mean they can't go home as easily, and we know which ones don't. But we have no way of aggregating that data. So they began to work with a technology company and created a command center that's about as big as this room that has decreased the need for 200 beds in that one hospital because the nurse's knowledge is now combined with AI and machine learning, and it's dramatically improving flow for patients across that entire hospital. So we're starting to see, I think, nurses as innovators from the patient voice all the way up to AI and machine learning make a huge difference in the way that our healthcare systems are working. Joost de Blok, a nurse in the Netherlands, again, from a source of frustration, redesigned the whole home care system and created a new way to think about how do we reach into the patients at their homes in a different way and create comprehensive care, which he calls Bertzog, which means neighborhood care. And I had the great joy to get on one of those big Dutch bicycles and go riding through Amsterdam to take care of patients with Joost and his team. But what I'm seeing is a great example of what you're all talking about this morning, and it is how do we reach and spread the models that we're talking about here so that everybody, every person in our country gets to benefit from this. We now have the opportunity to have interaction with our team for a little bit more than a half an hour, and so I open it up to our panel here in the room to ask questions, and Peter, I'll start with you. Go right ahead.
Well, thank you very much for coming. Thanks very much for coming. I appreciate it. And one of the things I wanted to focus in is on the screening part. And from my lens, I want you to kind of think that we're going to be making recommendations. And so think of a recommendation sort of thing. That's where I'm coming from. But what I want to ask you is everybody's screening, and which is good. But what is your sense about what happens after that? Is there a capacity out there to take these individuals? Is it an effective? Does it lead to anything that's effective? And where's the accountability? And so that could be Medicaid, it could be hospitals, whatever. So the capacity of who you're screening to, their effectiveness, and accountability. Can you comment about that? And because I'm thinking, maybe there's a recommendation that says we need to grow that capacity. Maybe not. Maybe you're all happy with it. I'd like to know, what do you think?
I can certainly start off answering that question. And certainly, at MinuteClinic, for example, with our nurse practitioner who interact with thousands of patients every day, and as we particularly worked with them and continue to work with them around moving from transactional episodic care to a more holistic patient-centric view, really looking at those areas of at-risk for folks, we together as a team with input from our direct care providers around important areas for screening for patients. So as part of CVS Health, for example, within MinuteClinic, every patient is screened for their whether or not they have a relationship with a primary care provider. first and foremost, as that triggers a system then behind the scenes which goes into effect to support a discussion about resources and engaging that patient at the end of the visit if they do not have a primary care provider relationship. In addition, we built in workflows so that all patients are screened around their smoking history. We are working most recently relative to screening around behavioral health and adding that into part of what we do, as well as medication, reconciliation, and those pieces there. So I think relative, and we are very proud of the results that we see relative to patients being screened and those discussions taking place. Part of that is on the front end, deciding as a team what makes sense in our setting, where are those areas that are important for us to point and activate our nursing workforce relative to screening the populations, and then creating workflows and systems as an organization that help our nurses not to miss opportunities. So there's a lot of hardwiring that happens within our workflow so that they're successful. I would say that the bigger piece of success, especially for our clinicians who are, in the community, is answering their question and concerns around, well, if I screen, for example, for depression, what happens next? Or, they answer, they have a positive PHQ-2, and then it moves to the 9, then what do I do? And part of organizational design in supporting that as an organization is not only supporting them to create local connections and resources, but also as a company to be thinking about where are those other partner organizations outside of our four walls who we can connect with, or social platforms that are being built that we need to collaborate with or be part of to start putting those tools in place of our nurses. I think for me the takeaway is they'll do it and they do a beautiful job, and find it and identify it as meaningful and some of the most important work they do each and every day. And part of our role in terms of, or I see my role as the chief nurse in organizing their work and supporting their success, is creating these relationships, developing these innovations and ideas. Can we work together? Even going outside of traditional healthcare systems, like big tech or other companies who are doing things with apps or information and data that can help us. It's complex, it's fragmented, and I think particularly in the areas of social determinants, a focus of leadership around creating those connections and programs going outside of our organizations is essential to enable the nurses to do terrific work that makes a difference.
Thank you. Priya, do you want to add?
Yes, I do. And I agree with everything Angela said. And I will say that when we started to have these conversations with our members a year and a half, 2 years ago around screening, one of the largest concerns they raised was that their teams aren't comfortable in asking the questions. One physician leader that we have said when he was a young physician, he didn't want to screen because he didn't know where to refer the patient to once they said they had a need, right? And so I think when you're looking at recommendations, more resources around screening are helpful to get teams trained to have those tough conversations, because they're not always easy conversations. They're challenging on the caregiver's part. They're challenging from the individual's part. Sometimes individuals don't want to talk about these things when they come in for their medical visits. So training and screening, but I think then there also needs to be resources around creating the pathways to connect those patients with resources. And those are different in every community, and those depend on what other resources are available. So hospital leaders, nurse leaders need the time, the resources to sort of build those connections, collaborations, and relationships in their community. And I think another area where a recommendation could be helpful is technology. We're starting to see a lot of different companies pop up that have created platforms that will connect hospital data with community-based organization data, so that when a hospital makes a referral out to a community-based organization, there's a tracking mechanism to make sure that the patient actually got that. Not all hospitals can afford to invest in those platforms. So there needs to be some accommodation for technology and that data flow back so that we can track the results adequately.
Thanks, Priya. Jack, do you have a question?
I didn't get my question answered. Can I rephrase it?
Sure.
Okay. My question was really, what's the capacity? When you screen out, is there capacity to do that? And is it effective? And is there an accountability, not the screening part?
Right.
But what happens later? I mean, we can all check a box and say, I screened.
Yeah.
Is that it? Or what happens next?
So from the work that we've done, I think by and large this idea that there's something shelf ready, that there are resources in the community and we're just not connecting them, I think that's a misnomer. There may be some. So there are things, for example, we know that individuals who are eligible for SNAP aren't enrolled in SNAP. So there are things like that where there are benefits out there and there's limited uptake. So there are things like that out there. But whether you're talking about housing or transportation, typically there aren't kind of shelf-ready things. This really requires a tailoring of resources to the medical needs and to the member or patient needs that present. So for example, there's a lot of work being done in Medicaid right now around non-emergency medical transportation. So finding ways to get patients to and from their visits. Uber may work for patients who can go and walk to their curb. Uber is not going to work for patients who have cognitive limitations, who have physical limitations, and need a more advanced form of transportation. So, there's an element of triage that needs to happen, and to a great extent, these services don't necessarily exist already in the community for providers to tap into. So it really is this piece of identifying potential partner organizations, but then taking what they're doing and really crafting it in a way that will really meet the needs of the patient. It's not as if you're just referring somebody and something is waiting to be uptake. It's not. And part of that is just because of the way those services have been developed. They haven't necessarily been developed with a healthcare lens in place. And part of that really is the partnership piece, right, between the two organizations. So I know that's really high level, but I would say things aren't ready for the referrals necessarily.
And I would like to just add that, and I'm sure you're all aware, but the community behavioral health services, there is a severe dearth of services available in many parts of our country. So that's one of the primary, flags that come up with the screening around depression. And I've talked to so many nurses that say we have so many patients with needs and there is really no place for them to be seen.
So to answer your question, as far as recommendation goes, thank you all. I hear us needing to identify the needs and then identify local resources that already exist and then build connections across the community. All three of those things, I think, were identified by our great panel. Jack, did you want to come in with a question?
Yes. Can you hear me?
Yes, we can.
Okay. It's a lovely day here at the World Health Organization in Geneva. I have a question for our colleague from CVS Aetna, and it has to do a couple aspects of this. It has to do largely with the issue of training of nurses at various levels, whether those are baccalaureate nurse students or advanced practice nurses or even DNPs in health hubs or in some of the similar settings that you have. Whether you mentioned one planning grant for the nursing school and the Hartford Age-Friendly program, but I wondered whether you had any plans to have any clinical training in these sites, particularly the health hubs. And then the secondary question relates to the workforce issue. 500 of these health hubs in a year is a lot, I think. Very ambitious. You have over 1,000 minute clinics, although many of those may be staffed by pharmacists, not nurses. That's still a lot. Are you having any issues in terms of focal limitations in nursing workforce?
So, thank you for the questions. First, relative to clinical training and health hubs. We do at MinuteClinic have a dedicated educator team that is staffed by nurse practitioners and physician assistants, and they develop, we use an extensive learning platform and have instructional designers on our teams as well. We're enabled by virtual technology and engage in just in terms of just general practice, a wide range of educational activities, including virtual grand rounds and education exchanges. We have an intranet loaded with clinical resources and interactive educational models. The educator team develops our national curriculum for each year and develops our training curriculum so that our practitioners receive full training on any new services, new guidelines, new equipment. We conduct annual skills assessments and privileging. We have a very robust clinical education training department, and we perform individual self-assessments and development plans and track each and every practitioner along their progress, and then annually renew skills and assess for areas of continued coaching. We also have, as part of our function of our educators, provide one-to-one provider, shoulder-to-shoulder coaching and training. We also have a team.
Let me interrupt for a second. I'm sorry, I wasn't clear. I'm certain that you have a robust training and evaluation and monitoring process for your employees. I was wondering whether you have students who are enrolled in nursing education who come and get instruction in the healthcare settings that you're talking about.
Yes, sorry for my misunderstanding. Yes, at MinuteClinic, we precept over 1,000 nurse practitioner students each and every year. We have partnerships with over 200 academic nurse practitioner programs across the country. We have an annual scholarship and grant foundation that awards hundreds of thousands of dollars each year to support the education of NPs nationally, and have a very robust student preceptorship program within our organization. More than half of our nurse practitioners engage in preceptorship activities. We also have an in-house student preceptorship training and certification program that practitioners within our organization who wish to precept students must complete successfulully to engage in that program.
We have lots of questions, so maybe you can come back to the second question that Jack had on the future workforce at some point, but I do want to make sure that we get around the room. So, Winston, how about you?
Thank you. This is a question principally for you, Tricia, for CHCS. You mentioned that, I think your words were, Medicaid agencies are pretty non-prescriptive as it comes to designating individuals or certain professional categories who do the implementation of Medicaid reform efforts. On the other hand, I imagine that a lot of the waivers and some of the MCO contracts specifically mention physicians playing a particular role in terms of establishing evidence-based protocols, et cetera. I assume so. Do you think there's actually a future or an opportunity to specify that nurses play a particular role in terms of identifying social needs and coordinating the roles, and that should be an aspect of kind of inserting certain expectations or languages around Medicaid implementation around waivers and or MCO contracts?
So I can't comment on the wisdom of that from a clinical care perspective. What I will say is that, traditionally, state Medicaid agencies, one, given that most of them administer their benefits in some ways through managed care plans, they are typically looking to their managed care organizations to do whatever kind of requirements around who does what, typically. A lot of that decision making is kind of delegated. So the approach that many of them take is, here are the goals, here are the requirements. Here's what we want you to do in setting up a care management plan. A lot of those dovetail with NCQA accreditation requirements. States don't all use NCQA accreditation, but they increasingly are. So it really is within the context of managed care that the state is looking to those managed care plans to work directly with the providers in a lot of instances. So I would say that typically the orientation of most Medicaid agencies and programs really is not to get into the ins and outs of who performs what. And that if you were to make a recommendation along those lines, there would be a significant gap between getting to that outcome and where state Medicaid agencies are now and how they approach their policy making.
Helpful, Tricia. I think that we've got some thinking to do about a recommendation potentially here. David.
Thank you so much, all of you, for the excellent presentations today. Many of you mentioned, there were several mentions of community health workers. Are there different models with which nurses work with community health workers, and are there some that work better than others?
I think, generally speaking, there are a variety of different models and ways that nurses, community health workers, social workers, volunteers, community advocates, whatever you want to call them, are working together to address social determinants. And I don't think we're at a point where we could say one is better than the other because they are so varied across the country. So sorry for a non-answer. I don't think we have one. But as Robin and I were preparing and thinking through what we were going to say today, we did have a conversation around how does education for nursing have to change so that they can be prepared to work outside of just nurses in addressing social determinants. Because I think, and I'm not a nurse, so please, anyone who is, correct me if I'm wrong, but I think there's the tendency, like in many professions, to work within your silo of nurses and not really have that training or understanding of how to cross-collaborate or lead other professionals. And so there is an opportunity there for more education and training.
Thank you, Priya. Regina.
Thank you, everyone. Those were, I think, really great presentations that'll be very helpful to the committee. So I had two thoughts that I wanted to ask about, really, Priya and Robin. So I think one of the things that you did that was really helpful was to provide some explicit examples of things that nurses are doing in the acute care setting that are really driving value. We were looking for things like that, and I actually think that was one of the things that was missing in the one chapter that we talked about with financing. You were able to show some outcomes data, including some elements of ROI, which I think are going to be really important. One of the things that I haven't seen in the literature is a lot of that. It may be because it is so new, but are you aware of published studies in that area? I mean, that would give us more detail that we could look at as we try to develop some case studies around and some examples around the work that you're describing or the type of work you're describing.
Yeah, so I can't think of any off the top of my head, but I have read some. So if you allow me some time, I will go back and find some and share those with you. I will say that the challenge at getting that ROI data is right now a lot of hospitals aren't measuring those types of things. There are a variety of different challenges that keep them from measuring that, real-time data, connection to what's happening once patients leave, a variety of different things. And one of the things we're trying to do as an association is pull together a list of metrics that hospitals can use to evaluate their social determinants program. So they move beyond just evaluating the number of patients that they're screening to get to the ROI. So I'm hopeful in time we'll have more of that data, but I will take that back, look at some, and then share them with Lori.
Thank you. And I would just add that the attribution of the nursing intervention is also very difficult to ascertain.
No, I mean, I think I hear something about data, a recommendation could come forth about how we need, I heard metrics come through a number of times. The other just very quick thing I wanted to say is you started out by talking about I'm not sure if it was a survey or something from the Chan School of Public Health, New York Times, and Becker's about nursing being the most trusted partner to change the healthcare system. So that also would be very helpful, I think, to this committee to learn and understand a little bit more about that. So if you could
that
give
was
us
October
that
30th
information.
And Deckers, and you have it? Is that what you said?
You
okay.
do? Okay. Just because I think that is, could be very, very, very helpful catalyst for us or platform. So thank you.
Thanks, Regina. Marshall, do you want to join?
Sure. Can people hear me?
Yes.
Great. So one of the main interests of the committee is health equity across a variety of factors, whether it's race, ethnicity, socioeconomic status, rural, urban, a variety of different factors. And importantly, addressing social determinants of health is not synonymous with advancing health equity. It's an important component, but in of itself alone won't fully address health equity. In Tricia's talk, she had a slide that talked about general principles of care coordination, team-based care, contracting, a variety of different factors. The very last presentation, Priya went through specific examples. Most of the talks were not specific and did not make the connection between some of the global questions or issues that Tricia mentioned, and then getting to how that and then encourages the specific examples, such as the one that Priya mentioned. Can you talk about what recommendations you would have then for enabling then nurses to be able to do the hard work of advancing health equity, which partly is social determinants of health, but it's more than that, but the specifics and the recommendations of how to encourage that, and also as a corollary, how to avoid the opposite in terms of actually purposely neglecting vulnerable populations, either purposely or as lack of prioritization.
Challenging question, Marshall. They look very pensive while they're...
So another issue that I cover at the AHA outside of value is our work on maternal health and child health and maternal mortality and morbidity specifically, and Robin and I work on that together. And I think that's a good example of where this health equity issue comes up. And beyond just screening for social determinants of health, I think there's a need for unconscious and implicit bias training across healthcare professionals. I think that would, address one piece of that health equity and get to sort of avoiding the opposite factor that you just mentioned in terms of neglecting certain groups. So that would be one recommendation that I would make. I don't know if you have anything else, Robin.
Well, Tricia, go ahead.
I would just also add, from the perspective of the AHA board and the AONL board, I mean, we are working on, organizations need to be led by a diverse governance structure. So how do we ensure that our boards and our leadership teams look like the communities they serve? And that's a challenge. And there was a few recent very good articles that I've read, and since I've been in my role a year plus, I mean, that's really one of my, major goals is to make sure that, our membership, our board looks like the communities. I can tell you from my past 35 years as a nurse leader, the past 20 as CNO in Atlantic City, New Jersey, that, that was something we struggled with, our nursing workforce. The population we served, the kids spoke 35 different languages at home. So when we looked at our patient population, and I looked at our nurses and our, the other members of the care team, I mean, we didn't look like the patients. And that was very distressing. And we put a number of programs together so that we were able to, provide scholarships and fellowships for underserved populations. And we made progress, but not enough. So, I mean, it's a very challenging question.
Patricia, you want to add?
Just quickly, I think, and this is not specific to nursing, but I think from the Medicaid perspective, one of the things that, because all of this is coming a lot of times in the context of value-based payment, things like, one, examining how those models are structured. There's a lot of literature coming out about how VBP models actually can exacerbate health equity and disparities. Mm-hmm. So, rewarding providers on improvement rather than attainment of specific goals or attainment of a specific percentile. using those mechanisms, requiring stratification of quality data based on race and ethnicity, really baking into the value-based payment approaches more intentional efforts around health equity that then filter down to the provider organization and down to the care teams. That would be what I would suggest.
Very helpful. We have two more questions, Marcus and then Vicki.
Thank you so much. This is kind of going to piggyback off Peter from the beginning, and there was kind of some talk throughout about cross-sector collaboration. I want to go back to that for a second, and perhaps Priya, Robin, and Elizabeth can weigh in here. So it goes back to your slide about, so 75% of hospitals are screening, I'm going to use housing as the example, are screening for housing issues, but only 46% are actually doing something to address it. But 85% of hospitals are focusing on health behaviors, diet, exercise, and other health-related behaviors. From my experience working with men who are homeless, they're not going to worry about their diet and exercise until they feel safe, have clothes on their back, and have a place to rest their head at night. So how are you working to shift the priority to focus on those, think about Maslow's, focus on those basic needs first before we can get to that activation and where people are trying to grow, but we are still increasingly lacking in addressing those basic needs.
Elizabeth, do you want to start?
Certainly. I want to make sure I'm not echoing again.
Sounds great here.
Okay. I will say that employers are recognizing the need for addressing health far beyond the healthcare system. They are trying to implement work site support. They are supporting community-based programs. They are truly trying to reach out beyond the traditional four walls of the healthcare system. But I think one of their key concerns is that the increasing cost of healthcare is directly undermining the social determinants. It is taking away from housing, transportation, healthy food. We are working at cross purposes. And one of the examples that I use is my daughter's public middle school cut sports to afford premium increases for their teachers. It is literally the opposite of what we might want to do to improve health. So in terms of health equity, I think it is not squarely on most of my members' agenda, but they recognize the importance. And I will say they are open to new approaches. But I think, as Tricia said, they are not sort of inserting themselves in how that gets done. They are just expecting it to be done and looking to hold systems accountable for total cost and total health through some of their measures and payment programs.
Very powerful, Elizabeth. Thank you. And our last question to Vicki.
Great. Thank you all for your remarks this morning. So I heard a couple of comments around using advanced analytics for decision-making, data exchange platforms, digital, texting, video. I wonder if you could comment on the readiness of the nursing workforce or any gaps that you have seen in nurses being these expert navigators and being able to handle the data that are being collected.
Angela.
Yes, thank you. Absolutely, there is a requirement that we support our nursing workforce to be successful. And I would say I am seeing in my practice in a few key areas relative to having conversations, casting the vision, providing training, opportunities to learn and to work through it. And those key areas would include technical innovation and the use of digital, the use of advancing technology, data, and analytics continually changes the way we understand and deliver health care, and helping the providers relative to receiving that information and then understanding what to do with it. And not only from we as healthcare systems sharing data and exchange and information. So, for example, our practitioners on our Epic platform can access Care Everywhere and view records and look at information from patients patient visits to other organizations, and helping them incorporate that into the workflow, prioritize that is an important part of how we train them and help to support them. The other area is supporting their understanding of the evolving payment models and the shift to value-based care, increased focus on improved health outcomes, and what does that mean for their practice. And in this regard, we work with them to share specific quality metrics, decide on those quality metrics, create performance dashboards, and from that develop ways that we can both tailor clinical education for them, but also support how we identify key priorities for patient outcomes and engage their buy-in and build-in as we create those models. The other area that we continually are working to advance our practitioner workforce is around the whole person care, moving from transactional care to looking at the whole patient, and how that is incorporated within the workflow, particularly in ambulatory care settings and such as ours. And then lastly, I would say one of the areas that we spend a lot of time in is what does the shifting in consumerism mean relative to a healthcare provider, as consumers have different expectations, and it's shifting to receiving the care that they need, when they need it, how they want it, at a cost that works for them. And that, I would say, has been a change for practitioners and helping practitioners. We talk a lot about patient satisfaction. We've had discussions around, is this really, is this a quality metric? And what does this mean? So those sort of behavior changes have been important parts of areas that we've been talking about and working with our practitioners to prepare them. Some of the things that we do in addition to education is, professional development courses, emerging leader courses, supporting that both internally and with benefits that support it externally as well. I would say that there's the change in healthcare. An important area is helping our nurses to understand the whys behind the change, how it ties into our continued vision and purpose as a practice, and helping them navigate through processes, systems, and workflows that help them be successful in this new age.
Robin, final word.
Yes, I would just add, and I agree with everything you said, Angela, this really begins, at the pre-licensure level. So the nursing programs, these are the domains that are necessary right now. As we look at nurses, throughout their careers, we do need to augment what they've learned, when they graduated and became registered nurses. So, I would just say right now we're partnering with a major technology company around clinician education, physician nursing, and other members of the team around AI. So it's very, very complex. Lots to learn.
So I am sure that you all of those of you who are joining remotely, and certainly all of those of us who are in this room, feel informed. I've learned so much this morning, energized. I really can sense the process that we should take forward with our recommendations, and inspired by all of you. So help me to thank our amazing panel for this morning. We're going to take a very brief break, and we're going to reconvene at 11 o'clock to hear from Laurie Melliker.
I really appreciated I do. I'm like, I want to get Sorry, dear. Oh, she is. Oh, yeah. No. When you sent a letter to me, I was like, I was going to say hi. I'm a Jersey girl. So, yeah. I live in Freehold. But I haven't. Oh my God. Our house is on the border of the first house in Freehold. So, I actually lived there when I worked in Philly. And then I have an apartment in Philly because I can't actually trains every day. So, but when you sent a letter to me, since I was
some of the trends that we've been spending our time and resources in exploring recently. You can see that they span a broad swath of disciplines and sectors, because it's not always easy once you get into studying, when a trend is just emerging, to really understand the implications that it might have for health. When we find a trend that we think will impact health, we go deep to learn more. So let me give you an example. 5 years ago, we began exploring the trend of artificial intelligence. Now, today, artificial intelligence is part of everyday life. It's our voice assistants like Siri and Alexa. It's self-driving Ubers in Pittsburgh. It's chatbots that help us with retail purchases. And it's also robots that are talking to my wrist. It's also robots that help us, that read our x-rays. AI is enabling a third wave of computing that is changing scientific discovery. It's shifting our business processes and models, and it's influencing all of us at a cultural level. In fact, as Amy Webb of the Future Today Institute shared with many of us at a workshop that she led at the National Academy of Sciences, it's really underselling AI to call it a trend. So back in 2015, my teammates and I set out to explore AI. It was a relatively new reality for most people. And we've all had our experiences with AI in science fiction, but what might it mean in our real lives? As we dug in, we heard some real concerns about this technology. Will AI eliminate jobs, and how will that affect the health of the current and future workforce? What ethics govern AI? Who's liable when AI makes a mistake that impacts the health or safety of someone, such as when an AI-driven vehicle hits someone? Will AI bake into place existing bias and discrimination, and will it create new disparities in health? Will the lack of transparency in who and how algorithms are developed lead to manipulation of human behavior to unhealthy means? Should the deployment of AI in healthcare be subject to clinical trials? So we made several grants to get a deeper understanding of the promise and also the pitfalls of AI, and to explore how our foundation and our grantees might harness artificial intelligence in order to help build a culture of health. So for example, we supported a team based at the University of Pennsylvania, which included Sendel Melanathan and Ziad Obermeyer, to develop a machine learning algorithm to explore how AI can enhance and improve human judgment in medicine. The prototype focuses on the early detection of sepsis, which can be deadly without treatment, to inform the behavior of emergency department physicians and nurses who are making decisions in extremely stressful situations. So in theory, this kind of innovation can help counter the implicit bias that leads to health disparities. But in reality, this team is showing us that the data on which they and many other teams are basing their algorithms has the potential to bake bias right into the decision support tool. We also supported the work of Khadija Ferryman, who produced a report that highlighted the risk of AI to increase disparities through precision medicine. As a result of her work, Khadija was asked to join the Institutional Review Board for the NIH All of Us research initiative that is basically creating the future of precision medicine. And in that role, Khadija is powerfully positioned to ensure that the use of AI can lead to a more equitable future. Now, these are just two examples of a really large body of work, and there's a lot more that we can do to influence AI development in order to ensure that it leads to a more equitable future. But I tell you these stories because when our team first started exploring artificial intelligence, it was so far out there. It was really outside of the realm of possibility. And it would have been really easy for us to just put that on the back burner while we all focused on these really urgent, important problems that the foundation was tackling. And if we had done that, the largest health foundation in the country wouldn't be asking the questions that Sendel and Khadija are asking. And we would have missed opportunities to explore how AI might put us on the path towards a more equitable future instead of just baking in the same inequities over and over again. So in July, my team brought futurist Amy Webb to lead a workshop at the National Academy of Sciences. Now, Amy is an expert in finding the future in the present, And she and her team at the Future Today Institute have developed and honed a methodology that harnesses the wisdom of experts in science and technology, but also in everyday life, to uncover signals of trends that might affect the future. She doesn't talk about her work as predicting the future, but she wants to make sure that her clients are not surprised by what the future may mean for their work. So during this workshop, she helped us understand that we should not be surprised by in-home diagnostics becoming widely available. We should expect technology companies to continue to expand into new industries, including finance, healthcare, transportation, and medicine, and reshape work streams, automate tasks, and organizational management for the health professions. We should be prepared for a world where private sector companies intentionally or unintentionally devalue existing board-certified licenses by launching their own certifications. We should expect more consumers gaining more access to ongoing diagnostics and information about their health to put a strain on our existing capacity. And we should think about what all this tech advancement will mean for health equity as communities continue to lack access to broadband. So we spent a day with Amy looking for signals about the future of nursing in the present. And what resulted from our meeting, you can see on this board, was a lot of signals, a lot of which weren't really on our radar screen as things that could be potentially important for the future of nursing. So the Pioneer team at the Foundation took these signals, and then we applied the methodology that Amy puts forward in her book, The Signals Are Talking, and we came up with a set of trends that we think may impact the future of nursing. So what you have, I think, in front of you, is it in the books or on the tables, is a list of trends. It is by no means a comprehensive set of trends. These are trends that we derived from the signals we collected, nor are they a set of trends that are exhaustive related to the future of healthcare. And what's also really important to note is that our understanding of the evidence base to support each of these trends really, really varies. Some of these trends may never come to fruition. So the document that you have also includes a set of questions to help the committee members and others really adopt a futurist mindset. And there are also a set of scenarios or stories that help you actually try on these futures, to imagine what the future might be and think more expansively about the future of nursing. So as I go through the trends, I hope you will consider these questions. And we'll have time at the end to have a discussion related to this. So we should be prepared for a world where there is increased prevalence and severity of climate change-related illnesses. According to the CDC, climate change with other natural and human-made health stressors influences human health and disease in numerous ways, including related to lung function, allergies, diseases carried by insects, food and waterborne diarrheal disease, food security, mental health and stress-related disorders, precipitation extremes, temperature extremes, and wildfires. So some existing health threats will worsen and new health threats will emerge, and not everyone is equally at risk. Important considerations include age, economics, resources, and location. We need to be prepared for a future where there may be increased variation in local and state legislation and regulation that affects health. As state and local governments take a more personalized approach to policy, the Foresight workshop participants observed an increase in the amount of variation in policy between states and localities at the local and state level. We should be prepared for more demand for on-demand health care. The Foresight, which is the name of the workshop that we held at the Academy of Sciences, the Foresight workshop participants observed that there's a trend towards more on-demand health care, pointing to examples like Doctor on Demand. And the Washington Post reported that millennials and Gen Z behind them are changing the way that they access health care. In fact, 45% of 18 to 29-year-olds say they don't have a primary care physician, and instead they're opting for on-demand health care. We should expect that more information from algorithms, there will be more information from algorithms to consider in care decisions. Though AI-driven technologies could be brought to bear on the weaknesses in the healthcare system we saw from our work with Khadija, but they could also exacerbate disparities.
We should be prepared for a future where AI-powered algorithms are increasingly being used by government agencies to determine eligibility and prioritize resource allocation. In the name of efficiency and cost reduction, AI is already being used by government agencies in many ways, ranging from eligibility determinations for disability benefits to profiling in child welfare cases, which is raising questions about due process and bias. An increasing amount of information is being shared by and about people without their consent. Spatial computing, AI, face prints, voice prints, and other technologies are becoming more ubiquitous in our daily life, and they are determining what and how we can access our rights. We can access our assets or our rights. Surveillance capitalism, which is the harvesting and harnessing of personal data to drive human behavior, also undergirds the online economy. Should be prepared for more opportunities for nurses to make decisions that have ethical implications. Now, nurses have always made decisions that have ethical implications. Foresight workshop participants observed that more rapid medical and surgical innovation means practice is moving faster than science, and that's moving faster than policy, and that will put health professionals in uncharted ethical territory. There are more and emerging vaping-related health complications to address. This came out of the Foresight workshop. The CDC announced in late October that the number of people who've died from vaping-related illness has increased to 42. Now, 42 deaths hardly describes a trend, but there's an increase in children and adults ingesting larger amounts of nicotine than they did before with traditional cigarettes, which might suggest that this trend might be really important. We should expect or anticipate an increase in the use of robots in care delivery. The use of robots in healthcare is a growing trend that seems to be gaining momentum in recent years. Right now in Japan, human-like robots are already being used as supplemental healthcare workers in elderly homes across the country. Larger robotic machines can be used to carry out laborious physical tasks like moving patients, and smaller interactive robots are being used to combat loneliness and inactivity in the elderly population. Researchers at the Georgia Institute of Technology recently developed a way to give robots the sense of touch using artificial skin. And we should anticipate what a future might look like if there is a decreasing reliance on traditional institutions. As private corporations flourish, there's been a structural shift in who delivers public goods and services. For example, companies like Amazon, JP Morgan, and Berkshire Hathaway are teaming up to disrupt healthcare and prevailing insurance models. At the same time, technology-enabled individual agency is replacing the need for traditional institutions as people look to social media influencers for advice and increasingly turn to alternative sources of healthcare such as telemedicine and at-home diagnostics. Okay, so this is where we're going to pause and turn the discussion over to you. I have the trends that we came up with on this slide, and would love for you to refer back to the questions that you have in front of you. I'd love to hear what you think about how we might harness these trends for a future that is more equitable. How might we mitigate the harms from these trends? Think through and actually make explicit how these trends might impact health equity. Take them a couple of steps if you can. And then really importantly, especially for me and my team, how might we learn more about these trends, whether these are trends at all and what they might mean for our work, and also learn more in a way that might help us identify opportunities to really harness them for good. So we'll open the discussion up to the room. I believe we're not doing online questions. Maureen?
This is fantastic. I had a question about the future of the nursing workforce. We've been talking a bit about that, but with 5 generations in the workforce for the first time and the increasing turnover of young people, I wonder how we can optimize some of these trends to actually create a vibrant workforce for the future by taking away some of the unnecessary work and making the work more vital.
It was a really great summary. I was looking at these lists of future trends, and aside from the first one, I think they represented a continuous trend towards commodification of health and health care. And most of our discussion this morning has been really around looking at so-called upstream or social determinants of health. I mean, I'm trying to insinuate what the implications in the future are with regards to looking at social determinants that really should not be a commodity, should not be actually services or goods that are rendered by private institutions. Do you have any thoughts about that?
So what I would love to do is ask if your colleagues have any thoughts about that. What I do know is that there are actually companies that are in the space of social determinants of health. Some of them are larger. Some of them, there are several startups. In particular, there's an organization called Acumen that invests in companies that are intended to have a return over the very long run and help those who are poor, not looking for a quick unicorn, and they're uncovering a lot of innovative companies that are in that space. But I would love others to go on your logic model trip with you and see what they think. There are many, so maybe we'll go around the room. Peter, and then Jose.
It was a different question, but I agree with you. I don't have an answer, but you said it. It made me think, wow, this is a commodification, and maybe there's good, but what does this all mean for our purpose? And I'm sort of like, whoa, you got me there.
Does anyone want to comment on this question? And then, yes, Jose?
So I was thinking sort of the same thing because it's so obvious, I think. But I guess the comment is that at least many of these trends, to the extent that they're going to actually, take place, they're actually occurring within a certain context that is both political and economical and, of course, technological and so forth. So to a large degree, they are shapeable. And so they're not, in my opinion at least, they're not sort of necessarily going to happen. They may happen under our current arrangements. And so it seems to me that it's really important to evaluate which of these we think are good in some big picture sense. You can pick your own sort of criteria for that, and which are not desirable. Because certainly political and economic arrangements influence these enormously. And those are modifiable, at least in theory, by decisions that people make, the people of a country. So, for example, I don't know to what degree these would be the trends that you would predict if you were in Europe. Perhaps they would be identical, but perhaps not. Mm-hmm. And perhaps they would change a great deal or differ a great deal across European countries, depending on their sort of political arrangements, their general sort of ethos, sense of sort of collective action versus individualism, etc. So anyway, I think that's the only idea that I have. Many of these to me, but of course, I'm older, are very off-putting, and several of them are very worrisome. And once you get them going on this track, then it's hard to know what it is that you're missing, because younger people, et cetera, for example, those who demand on-demand healthcare, they might get to a certain age where actually having an ongoing relationship with primary care providers and a system, et cetera, they would value a great deal, but they may never know that because they've never seen it, So anyway, I guess really the main point is these are not God-given, they're not preordained, they are modifiable by the political decisions that people make, and the political decisions in turn influence the economic arrangements that we have. And it's just worth keeping that in mind, I think.
Yeah. I think that's really important. I hope everyone really takes that to heart. The two examples that I gave were examples where, had we not been paying attention, those trends would have produced increases in disparities in the way that precision medicine is being created, and also so many hospitals around the country are trying to use algorithms to predict sepsis. We found this once we got in this space, it's happening all over the place. They're doing it with their own data in their own ways, and being able to raise up how that might actually not accomplish the goals. But you also make the point that even some of these, those examples are how particular trends you might be careful that they don't increase health inequities. But I also think we should be very open to the opportunity for where we think a trend is not what we want to happen, to influence forces that may impact that. And we have to be really creative and really take a systems perspective to understand which forces have that kind of impact. Bill?
No, thanks for this. So because you started with AI, more than half of what you have up on this list is information related. So my question is kind of a simple one. Why aren't misinformation and disinformation listed as a trend? There's certainly a trend in everything else, it seems.
So these trends came from signals that came out of the Foresight workshop, which also started with a discussion of AI. Amy is an expert in AI. This is, again, definitely not a comprehensive list, and we should add, you should be considering a wide range of trends that may impact our future. And we've actually done quite a bit of work at the foundation on misinformation to understand the problem. And also, there are a lot of innovators who are coming up with ways, both automated and not automated, to address that challenge in a lot of different realms that I'm happy to talk with you more about. Before I go to you, Peter, Jose, the one comment, thank you for the prompt about Europe. We have a team, our sister team at the foundation, which is Global Ideas for U.S. Solutions, that is scanning the globe for innovations that are taking place other places that might yield insights for us in the U.S. And I'll go to my colleague with this list to see what she might have to offer. Peter?
Lori, I want to say I thought this was fascinating reading. And I enjoyed the whole part. Sorry,
especially that part. Get that recorded.
Yeah, it was okay, Lori. No, this was great stuff. I really enjoyed this part of the book, and I want to point out to number 7, and because we are talking a lot about trust in nursing, but the actual questions that Gallup asks actually is tell how you would rate the honesty and ethical standards, and then so nurses rate high. Gallup turns that to trust, but it's ethical. That's the key word in this. And then you have this up there, and it feels like we're moving into a world where nurses will be making many more decisions. And it gets up to number 5 about priority. And it goes back to this question I was probing the prior group on is, what is the capacity of our resources? Because if you are in a decision-making role and you've got limited community resources, how are you going to make the decision of who gets my screen or my recommendation? And people have this view of nurses. And so I think for us in this board, we really, I think, want to talk a little bit about raising the level of education and preparation for making ethical decisions, because I think it's coming at us. And if we don't have a social determinants or health equity frame in that ethics, we could be missing something. So I just wanted to tie all that together.
I can't read. Angelica.
I just wanted to make a comment on increasing use of robots in care delivery. In nursing, we take real pride in our component of caring. We believe we do that very well. And that was one of the things to think about robots being caring. But you just mentioned that in Japan, they're using it for the elderly to help with isolation. So just a comment that it's maybe they can. I don't know.
I like the
Maureen?
I think to that point, nurses are probably uniquely placed to do digital care. And by that, I mean both kinds of digital care, digital AI and machine learning, but digital with our hands. And I think we're the profession that can really blend all of the aspects of digital care, but we should be pointing that out.
Wow. Trademark that. I get Jeff?
We always focus on digital technology. I think that often gets a lot of attention, but technology is really any new mental model or frame for how to do something often, or how to think about a problem. So I think the biggest revolution I've seen in healthcare is our deeper understanding of why people do what they do. And, you know, behaviors that seem illogical, self-destructive, senseless turn out to actually have a lot of grounding and, you know, much deeper understanding of adverse childhood experiences, motivational interviewing, kind of the trans-theoretical model of change. So just, it's interesting that that didn't come up. I feel like we tend to focus on really technology that is patentable and sellable rather than, it's pretty hard to, you can't patent motivational interviewing. But I think that's been a real revolution and not even completely recognized as occurring in front of us.
Yeah, we have what we call an opportunity space when we do a lot of programming in a particular area around the future of influence, which started with behavioral economics 9 or 10 years ago and has really evolved. I was thinking about that actually with the ethics, because now we're learning more and more about how you say something influences decisions in ways you may not understand and also the patient may not understand. And as we understand more about how when you talk about two treatment options in one way is more likely to influence a patient, there are definitely ethical considerations. And even the ethics of being really clear that you understand what the meaning of your words. So I think it could be in here, but this should also be the opportunity for you to suggest additional trends. I'm writing them down that you think should be considered in your work and other work. Peter?
On number 10, the decreasing reliance on traditional institutions. A week ago, I was reading in JAMA, and it was a study reporting, I forgot what they call it, crowd something, but basically it was a study showing people who had been diagnosed with a sexually transmittable disease, STI, whatever. And they were going, okay, then they're going to the web, going to a certain part on the web and say, this is what I've got, this is what it looks like, what do you all think? And getting this big crowd diagnosis. And some of them were saying, your provider's wrong. Others are doing this. And so it made me think of, is the internet, is the web a non-traditional institution for healthcare? And in that sense. And then I got to thinking, well, what about, could we use that to, if you need help on social determinants type issues, could we create a similar type of community where you go to that community for help, because these are people who've experienced it or living it, something like that. So kind of taking your idea about how do we turn this to an advantage. And I'm not being very articulate, but I think you get what I mean, right? Yeah.
Also patients like me for social determinants of health.
Yeah, maybe as a way to, to the point that question that you were asking before about what do you do when you screen, how do you identify resources? I mean, I think that they pointed out there's a dearth of resources. I mean, I think that's one of the major factors. So perhaps an internet community could identify resources as a
Marcus?
Yeah, just to piggyback off Jeff too, looking at this list, we talked a little bit about in our morning session about how do we enhance nursing education. Well, that's by adding in content on innovation and quality improvement methods so nurses know how to apply these types of thinking and methodologies to solve these types of problems, and they don't get enough of that in their preparation to understand that innovation isn't just technology, it's the way we provide care, it's the way we, clinical processes, workflows, and those types of things. Design thinking, the Rita and Alex Hillman Foundation and Penn Nursing just launched free resources for nurses in design thinking. So ways we can enhance curricula to address these trends that are provided here, I think it's important too, to expand the role of nurses.
That's great. David?
You mentioned that the foundation was doing work in the area of misinformation. I think misinformation is a challenge now, and I can only imagine it getting worse. Are there things that you are learning so far within the area of misinformation, of how professional organizations can respond, and what are the implications that it might have that I think we need to think about the future training of nurses? How do we train them to respond to the misinformation? We have the vaccine crisis as one dramatic example that affects a health domain and affects how health professionals respond to their patients, to their communities. So I just don't know if you've learned stuff in the area that could be helpful to us.
Yeah. So given where we are with our exploration, I don't feel comfortable in a public forum sharing what we are learning yet. What I can say is that we're getting a lot of proposals to address it. And there are a lot of different ways, not only to try to understand it, but also to even applying AI to identify it and to, people are thinking about this a lot. I also will say that we are not the evidence-based team at the foundation, so we actually try to share learning even when we're not entirely sure we know what we're seeing, and do some work to learn from a suite of projects, and can certainly share what we are learning as we're learning it over the next year. Would be happy to do that. Winston and then Greer.
So just going back to the number 7 observation around ethical implications, I think most people were thinking about nurses having more leverage around one-on-one interpersonal ethical decisions. But I think it's important also to frame this ethical within the context of populations and communities, because if we foresee nurses having a more visible and managed and augmented role in terms of policy, in terms of programmatic decisions, I think it has implications for how they play in the field of really considering ethical decisions that relate to wide swaths of community, and by extension have implications for creating health equity. So I think that's just an important caveat to how we think about ethical as not just interpersonal clinical decisions.
As I look at the trends here, it seems like all of them apply to all of the health professions. And so it makes me think about the interprofessional education and not the education just by our siloed approach. The other thing that occurs to me is that a number of these things, robots, working in non-traditional institutions, working with algorithms, most of our nursing students have no ability to do this clinically. And so we've got to match the ability of people to learn things in books and then actually practice them. And how do you do that when you've got so many schools in so many different locations, and thinking about a way to do that?
High schools in New York City, several of them are not teaching their high school students chemistry or biology or physics anymore. They're teaching them how this iPhone works for over the course of a semester. And so this interdisciplinary education is really going to catch on, and that will have implications. Maureen?
To build on Greer's point, I think one of the trends I see is new roles. So it's new education within existing roles. But I think we're going to see a whole raft of new roles in healthcare, particularly as we're dealing with equity and we're working out in the community. We might start to see more community health workers as being part of the health system, and new psychiatric support folks out in the community who now become part of the health system. So it's just an area of focus, I think.
Okay. Thank you very much. I have one more slide to encourage you to, hopefully these trends put little sparks in your head, little hunches in your head, some of which you articulated now, some of which will occur to you in the middle of the night. And as you end up talking to your colleagues, hopefully, about these trends, want to really encourage you to visit a site we've just recently launched. It's actually we're only sharing it with limited audiences right now as we pilot it. An opportunity for you to share your hunches with my team and with the foundation. And when you go to the site, shareyourhunch.org, you can also scroll down and see hundreds, actually, already of hunches that other people have shared. These are collected from audiences we have visited, but do not all relate to the health realm at all, except that they all do end up relating to the health realm. Yes. We do, yes.
Could we go back in time retrospectively and imagine this talk was given 5 years ago or 7 years ago? Do you think that people in that room would have said social determinants of health is going to be a big deal in the 2020s? Because I guess what I'm trying to get at is a little bit of nervousness that, is this the new fad, like teamwork was after the ACA? And I don't think it is, but I would like a little firmer basis about why now, why this, why so important, why does it all seem to be gathering here, and capture what those are, because I think that could be important in our report to say these are the momentum, the trends that have shaped where we're at today. So I guess I'm saying go back in time, Lori, and just imagine yourself. What if anybody predicted this 5, 7, 8 years ago?
So 5 years ago, you were seeing signals from the fringe that this was going to be important. In fact, I work within the foundation. I was seeing it a lot, that there was a hope that this was going to be important, and there were innovative organizations and companies that were popping up to address it. Now, there's always a question about whether something is trendy or whether it's a trend, and I would encourage all of you to go buy Amy's book. And she talks about, in particular, the laws of trends, which we, even mentioning it makes me nervous because we don't have time to go into it, but she talks about a trend is something that's timely, but it persists. And this is something that might be especially helpful. It's driven by a basic human need. It evolves as it emerges, and it forms from weak signals on the fringe. So I guess my answer to you in the context of this talk is that I would not have predicted, but I sure would have wanted to anticipate that we would be ready, including with your really wise questions about capacity, that if we did get to the place where all this stuff that we're really trying to do works and we do get people screening for social determinants of health, let's make sure that we're ready to address that need. would have been great. Okay, so anything else before I just conclude? To again encourage more of you to continue to do. Many of you have experienced Amy's workshop. You can certainly get access to her book. Encourage more of you to engage in this trend sensing work as an amateur or in your work, because I have one more. Because. And this is a quote from Hannah Fry, who's a new promising young mathematician. The future doesn't just happen, we create it. So thank you for your efforts to help create a future that is more equitable. Thank you.
And we certainly want to say a very big thank you to Lori, as well as to all the other presenters who joined us today. They've certainly provided a lot of stimulation and things to carefully deliberate on. So we are thankful to them for their valuable information. We also want to say a very special thank you to all the viewers who have taken time to be with us and to listen to this open session today. For all of the viewers out there, we want to encourage you to submit any comments that you have had to this or any other aspect of our work via email at futureofnursing2030@nas.edu. That's futureofnursing2030@nas.edu. That's also listed in the handout of information on the right side of your screen. This is our last open session until the report is released next year. To make sure you receive notice about the report release, be sure to be on our listserv. And again, thank you so very much for joining us today.